Assalamu alaikum, this is RPH with a new video of the antimicrobial drug from the series of antimicrobial therapy. Basically, antimicrobial drug covers the two diseases, that is tuberculosis and leprosy. So, let's begin the video with the therapeutic goals. Therapeutic goals of the any selection of the drug regimen is prevention or prophylaxis of the particular disease, cure of the clinical disease, requirement, prolonged therapy that will match the patient condition. Also, compliance of the patient is also the integral part of the therapeutic goal. Combined therapy, because monotherapy increase the resistance chances. Prevention of the development of drug resistance that can be cured or prevented by the selection of the combined therapy. Cure ideally 95 to 100%. So the combination therapy of anti-TB drug should delay the emergence of the resistance and increase the antimycobacterial efficacy. Properties of the Mycobacterium tuberculosis, that is his highly lipid structure. Its cell wall is highly lipid, that is 60% dry weight. Mycolic acid, a major component, slow growth, survive within phagocytes. Difference between LTBI and the TB. LTBI is the latent tuberculosis infection and the TB is simply tuberculosis. So what is a basic difference between the LTBI and the TB? When Mycobacterium tuberculosis infected an individual, it causes the infection which is called as LTBI. And when the same pathogen, that is Mycobacterium tuberculosis, cause a disease, it is called the tuberculosis. In infection, the symptoms are minor or mild, while in the case of the disease, there are the more worsened symptoms. And also its treatment is different. Mechanism of action of the first-line drug. The first-line drugs include ISONIAZID, PYRAZINAMIDE, Ethambutol, and Rifampicin. Isoniazid, journal comments, it is used as a prophylaxis as a single agent. Its resistance rate when used as a monotherapy is 10 to power 6 to 8, and when it is used in the combination therapy, its resistance will gradually decreases, that is 10 to power 12. Antibacterial activity, it is bacteriostatic at most concentration and is bactericidal to actively growing organism. Its mechanism of action, it inhibits the mycolic acid synthesis. And how it inhibits the mycolic acid synthesis? Basically, isoniazid is a prodrug which will activate by the action of the catalase peroxidase. Catalase peroxidase activate the isoniazid into the active metabolite that will target the INHA. INHA is the acyl carrier protein reductase, which is important for the synthesis of the mycolic acid. So when it inhibits the INHA, it ultimately disrupts the synthesis of mycolic acid. Mycolic acid is the important and the characteristic part or the component of the mycobacterial cell wall. So it's ultimately lead to the disruption of bacterial cell wall. Now the next point is CatG gene. What is CatG gene? Basically, isoniazid when converted into its active form by the action of catalase peroxidase, this enzyme is encoded on the gene called CatG gene. So due to any deletion and the mutation in the CatG gene will lead to the resistance. Its resistance pattern, 8 to 10% of isolate in the US are resistance. Pharmacokinetics. It can be given orally, well absorbed, distributed, intracellular, CSF, necrotic material elimination by the process of acetylation. The enzyme is present in the liver called N-acetyltransferase. This is the simple pharmacokinetics, summarized pharmacokinetics. There are basically two types of the peoples are present. Either they are fast acetylator or slow acetylators. The fast acetylators acetyl or inactivate the drug into the 60 to 90 minutes, while in the case of the slow acetylator do the same mechanism in the same process in the 3 to 4 hours. ISONAZID by the action of the N-acetyltransferase convert into the N-acetyl ISONIAZID, and then by the process of the hydrolysis in the phase 1 it is converted into the isonicotinic acid and acetyl hydrazine. The individuals are either slow acetylators or the fast acetylators. It is depend upon the genetic polymorphism. Slow acetylator are at the high risk of the developing neuritis. Why? Because it will not metabolize or inactivate the drug, so the active form is increases in the blood, which will lead to the toxicity, that is neuritis. ISONAZID INH is indicated isonazid converted into the acetyl isonazid by the action of the N-acetyltransferase. Acetyl isonazid is a hepatotoxic. The rate of the above reaction varies in the different people as I described previously because of the genetic polymorphism. Is that the reaction may be the rapid or slow. People are classified as the rapid acetylator. The rate of the reaction is rapid, forming acetyl isonazid, that is 30 to 40%, and slow acetylators, rate of reaction is slow, that is 60 to 70%. So their plasma half-life is also varies because it inactivated in different times. In the rapid acetylator it is 1 hour, in slow it is 3 hours. Now the question, why slow acetylator are prescribed with the low dose of the isoniazid? It's my question. Write your answer in the in the comment, and I described this answer in the previous slides. Adverse effect, that are the common adverse effect: allergy including fever, skin eruption, hepatitis, and various kind of the rashes. Hematological thrombocytopenia, agranulocytosis, eosinophilia, and anemia. Reversible vasculitis may occur and arthritic symptoms at the various joint may observe. But what are the major side effects or the adverse effect of the isoniazid that are the characteristic side effect of the isoniazid? That are hepatitis, because it forming the toxic metabolite. Must memorize its toxic metabolite because it is important. Hepatitis, there are the two types of the hepatitis, either minor or major. The major is called the clinical hepatitis, at which you should cease the drug. At the minor hepatitis, increase in the level of the aminotransferase, and you should not recommend to stop the drug because it is asymptomatic and not lethal or worsen. Okay, in the case of the clinical hepatitis, stop the drug or cease the drug. And what is the indication of the clinical hepatitis? That is loss of the appetite, nausea, vomiting, jaundice, and upper right quadrant pain. Most notable side effect is peripheral neuritis, including optic neuritis. Why? Because isoniazid has a structurally similar to the pyridoxine, that is vitamin B6. So it is also called the peripheral neuropathy. Because of the decreased concentration of the vitamin B6, It will cause the peripheral neuropathy, and the symptoms or the indication of the peripheral neuropathy you can see in the picture, that is tingling, stabbing, numbness. You cannot feel anything. I feel like I'm wearing the gloves, muscle pain and the weakness. Okay. Now in the 20% peoples, if given greater than 5 mg per kg per day, but infrequent in the standard dose of this, that is 300 mg per adult, assuming 70 kg as standard. 300 is 4.3 mg per kg. These are basically the clinical calculations. This is somehow conceptual and tricky. Predisposing conditions: low acetylators, malnutrition, alcoholism, diabetes, AIDS, uremia. So you should give the supplement with the pyridoxine, that is a vitamin B6, because vitamin B6 deficiency can cause the peripheral neuropathy. Then here is my second question. Must write your answer in the comment. Why Mycobacterium are resistant to many other drugs? Then the second drug from the first line therapy of the tuberculosis is Rifampicin. Its mechanism of action: bind to the DNA dependent RNA polymerase, inhibit initiation, not elongation. Antibacterial spectrum: M. tuberculosis, bactericidal, broad spectrum of bacteria, many gram-negative and many chlamydia. Pharmacokinetics: it can be given orally, well absorbed, distributive, even in a CSF. Orange-red color restraint tissue secretion in the urine. This is the characteristic of the Rifampicin. Drug and metabolite eliminated in the feces. Autoinduction of metabolism: half short life, that is 40% for the first 14 days of the treatment. Why? Because it will autoinduction. It will show autoinduction. What is an autoinduction? Basically, Rifampicin is the enzyme inducer of the particular enzyme. What are these enzymes? That are cytochrome P450, 1A2, 3A4, 2C9, 2C19 and 2D6. So when it induces the enzyme, it itself metabolite own drug, that is Rifampicin. This phenomena is called the autoinduction. So in the treatment, first 14 days of the treatment, half-life is shortened because of the hepatic microsomal induction, that is the enzyme of microsomal system. What the uniqueness of the Rifampicin? Basically, Rifampicin have the unique characteristic among all the antimicrobacterial drug, that is only drug penetrate in the lung cavity, highly active against intracellular pathogen in the lung cavity. Clinical use: tuberculosis. Never use alone for the therapy of the tuberculosis because it will increase the chances of the resistance. Leprosy, various bacterial infection, and most precisely and importantly MRSA with vancomycin and PRSP with penicillin. Its major adverse effect is flu-like syndrome, which is characterized by the fever, chills, malaria, acute renal failure, and hemolytic anemia and shock. Hepatic microsomal induction, so it will interact with the drugs that will activate or metabolized by these enzymes. What are these drugs? That are anticonvulsant, oral contraceptives, warfarin, cyclosporin. If the patient taking these drugs with the Rifampicin, so we switch to the Rifabutin, that is another rifamycin with the less enzymatic inducing action. Resistance pattern. Frequency of the resistance is 1:6. Organism develop quickly due to the changes in the beta subunit of the DNA dependent RNA polymerase, because it is precisely inhibit or acting on the DNA dependent RNA polymerase. Not use drug alone for the TB, as I defined the reason previously. Due to the high drug interaction, switch to the next drug. And what is that drug? That is a rifampicin.